Establishing the clinical baseline for fetal growth in the second and third trimesters relies on 4 highly specific ultrasound measurements. This diagram shows the required cranial metrics. The biparietal diameter is measured across the thalamus, starting from the outermost edge of the near skull and ending precisely at the inner table of the far skull, deliberately excluding the outer boundary. This is recorded on the same plane as the head circumference, which maps the perimeter while explicitly excluding the skin. Below the skull, we measure the abdominal circumference at the junction of the umbilical and left portal veins, omitting subcutaneous soft tissues. Finally, the femur length is taken across the longest dimension of the femoral shaft, strictly excluding the epiphysis. The ultrasound machine synthesizes these 4 specific data points to calculate a composite gestational age and an estimated fetal weight. When the calculation plots a fetus below the 10th percentile, the clinician must determine if the measurement indicates a constitutionally small fetus or an active pathology. To differentiate a healthy, small fetus from one in severe danger, we have to look past the top-line dimensions and identify the specific physiological markers of intrauterine growth restriction, or IUGR. Intrauterine growth restriction manifests in 2 distinct anatomical phenotypes. The first is symmetric IUGR, a global restriction of growth that presents early, often clearly visible in the first trimester. This symmetric failure to grow is driven entirely by intrinsic biological errors. The primary culprits are chromosomal anomalies or congenital torch infections such as syphilis. Because the restriction affects the entire organism uniformly, the head and the body both remain small. The clinical prognosis is universally poor, as the fetal brain is restricted from developing normally. The second phenotype, asymmetric IUGR, operates on a completely different timeline. It appears later, typically in the second or third trimester, and is triggered by extrinsic environmental factors rather than intrinsic defects. Physiologically, this condition restricts weight before it restricts length. The result is a highly specific anatomy. The fetal body becomes disproportionately small, reflected in a low abdominal circumference, while the head size remains completely normal. This distinct asymmetry is driven by placental insufficiency. It is almost exclusively the result of maternal vascular issues, specifically chronic high blood pressure or preeclampsia choking off resources to the placenta. The preserved head size confirms that resources are being prioritized for the brain, but physical dimensions cannot confirm if the organ is actually receiving adequate oxygen. For that, we must measure the invisible fluid dynamics of the blood itself. A successful pregnancy requires the vascular resistance in the umbilical artery to progressively drop as gestational age advances. Early in development, the fetus functions metabolically like a muscle, requiring heavy blood flow only intermittently. As the fetus approaches viable age, its metabolic demands transform. It becomes a highly developed brain, an organ requiring constant, uninterrupted energy. This Doppler waveform charts that exact progression. You see high resistance in sharp systolic peaks, with diastolic troughs dropping to the 0 line. Watch the waveform shift. Troughs rise, establishing continuous flow. Clinicians track this SD ratio, dropping below 3 by 34 weeks. A healthy, rising diastolic flow is the mechanical proof that the umbilical system has adapted to support a complex, neurologically demanding organism. When maternal preeclampsia damages the placenta, that delicate low-resistance system is violently disrupted. The resulting placental insufficiency causes a massive spike in downstream vascular resistance. This high resistance actively chokes the umbilical artery. As the placenta fails further, the pressure prevents forward movement of blood. In extreme cases, resistance becomes so immense that blood is pushed backward. Watch the umbilical Doppler waveform react to this pathology. Healthy diastolic flow plummets downward into a high-resistance spike. Then the flow flattens completely against the baseline, absent diastolic flow. Finally, the trough dips below the baseline, indicating reverse diastolic flow. Both absent and reverse diastolic flow are critical warning signs. They indicate an impending fetal failure and are associated with a devastatingly poor prognosis. Measuring the umbilical resistance gives us the precise status of a failing placenta. But to understand how the fetus is neurologically responding to this suffocation, we have to look directly inside the fetal skull. The primary window into fetal cerebral hemodynamics is the middle cerebral artery, or MCA, measured precisely at the proximal third of the vessel. When a failing placenta induces severe hypoxia, the fetal autonomic nervous system executes a survival protocol known as the brain-sparing reflex. To protect central neurological function, the cerebral vasculature actively dilates, attempting to forcefully siphon oxygenated blood into the brain. This tracing shows the normal baseline state of a healthy fetal MCA, a strictly high-resistance vessel with sharp systolic peaks and very low diastolic flow. Watch the desperate vasodilation drastically alter the tracing. The low diastolic flow rises significantly, dropping the overall resistance. Clinicians frequently observe an absolute increase in peak systolic flow at this stage, a final hemodynamic warning that often precedes the onset of fatal hydrops. High diastolic flow in the MCA is not an indicator of healthy brain activity. It is evidence of systemic prioritization, sacrificing growth to maintain oxygenation. To accurately evaluate the severity of this brain-sparing reflex, clinicians rely on a definitive mathematical metric known as the cerebroplacental ratio, or CPR. The CPR divides the pulsatility in the middle cerebral artery by the umbilical artery. Normally, high MCA and low umbilical resistance yield a ratio above 1:1. When conditions invert, high MCA diastolic combined with decreased umbilical flow, the CPR drops below 1:1. Infants surviving with an inverted ratio face severe long-term consequences, marked by significant deficits in cognitive functioning and poor academic achievement. Ultimately, the cerebroplacental ratio identifies the specific point of hemodynamic failure that correlates with these future cognitive deficits. Hemodynamic data identifies the mechanics of distress, but it must be paired with physical observation. Clinicians use the biophysical profile, or BPP, to evaluate both acute and chronic hypoxia over a 30-minute observational window. This clinical matrix outlines the specific observational criteria. To assess acute hypoxia and assign normal diagnostic points, a sonographer must verify 4 distinct physical markers. Observe 3 discrete fetal movements, 1 episode of extension and flexion, 30 seconds of continuous breathing motion, and 2 heart rate accelerations. Those rapid acute events are contrasted by a single, slow-developing indicator used to assess chronic hypoxia, the presence of at least 1 pocket of amniotic fluid measuring greater than 2 centimeters. If the fluid volume depletes, resulting in severe oligohydramnios, alongside a restrictive anatomical measurement, it confirms a long-term pattern of placental insufficiency. Synthesizing anatomical biometrics, Doppler indices, and physical parameters provides the data necessary to evaluate the systemic mechanics of fetal survival.